Well, it should be pretty exciting because I have a great panel here to work with. And the title of this, of course, is The Future of Big Data Analytics in Healthcare Challenges and Opportunities. I wanted to tell you a little bit about the fact that as a physician when I was practicing, this big data, what we're talking about, is pretty counterintuitive when you really think about it. Here you are as a patient right in front of me, yet when you really look at it, medicine wants to look at millions of other people in order to determine how best to help you. Now, this idea, looking broadly to focus narrowly, is central to a paradigm shift, as we've been talking about all day, moving medical decision-making away from ad hoc and toward evidence-based. You've heard that term used today. I want to use a specific example in a recent issue of Fast Company. Many of you probably read Fast Company. They talked about data bloom, and they gave a great example. They cited about some emergency room doctors at a Washington Hospital Center in D.C. It's interesting how we're talking a lot about emergency departments, because if you really look at cost of care, you saw some of that evidence today about how much it costs and how overutilization is, as Bassett showed this morning, that approximately 70% of visits to the ED are probably unnecessary. Well, they were noticing a troubling trend, these physicians, and what they noticed was that a large number of patients were returning to the emergency department sick again within a few weeks of being discharged. So they believed that a large amount of these readmissions could be prevented with better follow-up care, but they had no way to predict which patients were most likely to become ill again. They began to work with Eric Horowitz, MD, who's a physician. He's a computer scientist who works at Microsoft Research, John, so you probably know him. Anyway, he and his colleagues built a system to analyze more than 300,000 ER visits. And they stumbled on a few intriguing things upon analyzing the data. One was the length of a patient's stay in the ED. So the length of the patient's stay, and the tipping point was 14 hours. Now, if you're in the ED for longer than that, there's a real good chance you'll be back. That's what they found. Another red flag was fluid. In other words, the data showed that any mention of the word in a patient's chart significantly increased the likelihood of readmission. So as a physician, if you had asked me before that, I would not have picked these two things to be able to predict that. But I thought that was fascinating. I want to introduce the panel today because I think you'll be impressed with their backgrounds. I think first I'm going to introduce the female in the crowd, Wendy Angelo. Wendy is at Phoenix Children's Hospital, and I'm not going to read all their bios. It's on the program site, but I just want to highlight a few things about what they're interested in the work they're doing. And we're really grateful for her to be here today because she's in the midst of really doing an implementation, which is probably driving her crazy, as most implementations are. And so we appreciate her coming down here. But she's the CMO at the Phoenix Children's Hospital, and she's working particularly at optimizing and development and deploying of an ambulatory electronic healthcare record. She comes from New Hampshire. She's worked there before. She's been in Phoenix for about a year. She really likes, and I think this is really critical to some of the discussion, translating clinical needs of providers and patients into efficient clinical workflows. Part of it, she has been very interested in working in population management and is engaged in how to utilize data sets within healthcare, which is really pretty critical. John Barto, who is next to her there, is a healthcare evangelist from Microsoft Corporation. You'll have to ask him what that means, because hopefully we're all healthcare evangelists when you think of it, IT evangelists. But John started his career in Ohio. He worked in a county hospital there, building their information technology stuff. Then he moved to the payer side with Blue Cross and Blue Shield of Michigan, and does a lot of work now consulting for Microsoft in the area of information technology. And I'm going to particularly ask him in a question later on about health information exchanges, which has been a real dilemma for us, for a lot of us. And so I'll be anxious to hear what he said. Joe Colorafi is with, he's with Dignity. Since Banner was a sponsor, he used to be with Banner, so now he's the Chief Medical Officer for Dignity Healthcare, doing a lot of traveling. He's been involved in medical informatics for about 13 years. He's been involved in systematically and successfully implementing electronic health records, working on patient safety and quality in the system he's worked in. But he's also doing something very interesting now, which I hope he discusses a little bit with you, which is some of the work that Dignity Health is doing with SaaS. They're aggregating disparate databases while creating health analytic models, which through private cloud strategy. On his far side is Yves Lussier. Yves is here at the University of Arizona. He's the Associate Director for Informatics of Bio5, which he's going to have to explain what that means to us, I think, and the Cancer Center, as well as Associate Vice President for Health Science of the University. He's been obviously a physician, but he's had engineering degrees and completed a postgraduate training in the Department of Biomedical Informatics at Columbia. So we really have a really high-powered panel today, and what I've asked them to do is to each talk about 5 minutes, take about 5 minutes to get their perspective and the work their organization is doing in this area. So I'm going to sort of hold them to that 5 to 7 minutes because I want to make sure we have plenty of time for questions. I have some questions I'm going to ask once we're finished the panel, and then I'm going to open up to the audience. So I think I'll start first with Wendy, since I started her with the introduction. So Wendy, I'll turn it over to you.
Well, thank you for having me. I want to just walk through a little bit about the evolution of medicine and big data, and really hone in on the fact that the whole situation in medicine and big data is fluid. It changes every 5 or so years. And having been in medicine 20 plus, and I won't say how long the plus is, years, I've been witness to it. So when I started out, we started in what was called, what's now referred to as the P0 period, and this will make more sense as I go along. And basically that's when there was an expert model. You went to the doctors, and the doctor told you what to do, didn't ask you what you wanted to do, didn't ask you what your opinion was, didn't ask you what your finances were. You just did what the doctor said. Nobody questioned it. It was paternalistic, and it went forward. At that point in time, everyone wanted to see the old doctor. The older you were, the better doctor you were, right? Think about Marcus Welby. And that's because the big data in that model was the experiences of the physician. So that was the only data that really existed during that time period. And that's kind of what was referenced in one of the earlier lectures when Larry Weed was doing the SOAP note formats and such. Go forward into the early, late 1990s, early 2000s, and you start getting into the P3 period where we're talking about prevention, predictive, and personalized medicine. So randomized controlled studies are all the rage. I mean, if it's not, coming from that, then it's not valid. Data registries are coming into their own, and something called evidence-based medicine is really evolving. At that point, we're starting to personalize medicine based on the evidence. So we say, you have a family history of heart disease, therefore, and you're a smoker, therefore your risk of a heart attack over the next 10 years is 14%. If you quit smoking, it goes down to 8%. My personalized prevention plan for you is quit smoking, because you can't pretend you're adopted. So it's the only intervention I can do at that point. Interesting, that's about the same period where data started, the amount of data we were producing was increasing exponentially, and in 2003, that 1 year alone, we produced more data than we had in all of history prior to that. So you can see how the data and the evolution of how medicine's being practiced are following each other. Then we get into what Leroy Hood refers to P4, and that's how all these P's started off. And that's a period where we took what was in P3, the prevention, the predictive, the personalized, and we added participatory. And this is kind of the cutting edge of right now where we're at. We have sites like Patients Like Me, where patients are educating other patients. This site has 250,000 members, 2,000 conditions, 22 million, data points. And patients can basically go on that site and say, okay, well, I have rheumatoid arthritis, and my doctor says I should be on Enbrel, but I have been having this weird numbness in my arm. He says it's not related. Has anybody else have that? And they can actually see that 22% of people who took Enbrel had that symptom, even though it's not reported, but people who've actually taken it have had it. They also can go on social media, which has been talked about a lot today, and the wearables are really coming into play with all of this. So now the big data really is patient feedback, massive data registries, and Google is part of our big data for healthcare, right? Because everyone Googles. The first thing you do when you get a diagnosis is you go and you Google, or if you have a symptom. The next evolution up is P5, which is all the things we just talked about, plus psychocognitive interventions. What do I mean by that? Your doctor says you have diabetes, you're overweight, and you need to exercise. Well, I got an app for that. And actually, some doctors are starting to prescribe apps, right? I've got an app that's going to fit with the way you think. You're going to pick an app that goes along with your cognitive understanding of your condition, meaning what triggers work for you, and it's going to give you feedback. The part that's not happening is it should be a continuous loop. As you exercise, it should tell you how you're now lowering that risk of your diseases, and that's where we're going to. So that's kind of cutting edge, I would call. Bleeding edge right now is crowdsourcing healthcare. There was a great article done about a guy named Salvatore, and I'm going to not get his last name right, Icanes, I think. And he was a computer science gentleman who was also an artist. And he unfortunately developed a brain tumor. First thing he did was he put all of his healthcare data on the web. And to quote him, he says, "Cure is not unique." He says, "There's a cure for your body, there's a cure for your soul, and everyone has a possible cure for me, and I'm willing to listen to them all." And within 24 hours, he got 300 different replies, some from artists, some from healthcare people. But that's a new source. I'm not even sure what you call big data in that circumstance. It's the totality of knowledge when you get to that evolution. At Phoenix Children's Hospital, we are really working towards being on the cutting to bleeding edge. We just got a new center that we're doing with Dr. Patrick Sun-Shin, who does Genomics America. And we're going to be doing a lot of personalized medicine with him. That's my story.
So thank you, and I'll have a pretty good question for you after that. So John, I'm going to turn to you now, if you don't mind, if that's okay with you.
Thank you. Can you hear me okay?
Yeah.
Okay, so
Why don't you move the microphone?
Do you want me to push it
towards you?
toward me?
Yeah,
Okay.
yeah.
So the question always is, what is a healthcare evangelist? So I'll touch that just a little bit. I've actually carried that title in my jobs since about 12 years ago. And what I learned is I was a CIO in a hospital, a very small concern many years ago when we were implementing technology and struggled with a lot of things. But one of the things we never got a good chance to do was to get out in front of the medical professionals and show them how technology could make a change. Everyone says this industry is very far behind as far as adopting technology. One of the things I always say to that is, we're not really as far behind as you think. We're far behind where we're not incented to adopt technology. Take a look at medical imaging, for example. In the area of Dallas, where Parkland is, we have more medical imaging equipment than most continents do, right? And so the reason for that is because we were remunerated and incented for that. And so one of the things that I chose to do in my career path is to move from technology company to technology company. And I recently chose to join Microsoft about 4 years ago. And my reason for joining Microsoft is because the next main move is, how do you consumerize and how do you touch patients? And I was looking for an institute where I could find the capability of touching patients or consumers that they do every day, as well as some enterprise class capability. And at the time when I chose this job, I actually had an offer from Apple, which I'm surprised to see what they're doing now. Maybe I wish I would have taken that. You never know. I had an offer from Google, and I had an offer from Microsoft. And I chose Microsoft because of its consumer reach in my mind. It was both an enterprise and a consumer touch. So what my job is now is I get the opportunity to actually work with all our account teams that go out and focus on healthcare institutes, whether that be payers or providers or life sciences organizations, and actually represent, not typically to the IT personnel, but to the people in the field, how our technology can make a difference. And a couple of stories in that space is and if you want to, you have an opportunity to do this. Arizona HIE is hosting a session coming up at the 29th and 30th where we have one of the success stories where we brought a partner into Carolinas Health and actually helped them do some predictive modeling around COPD, finding new patients that they weren't there by observation alone, and then secondarily actually helping them figure out how to manage those patients based on their characteristics, and going from predictive, fringing on the prescriptive, because now that we know these interventions work for these types of people, maybe we ought to guide you in that direction. Not all the way to FDA guidance or anything yet, so don't worry about that. So that's somewhat some of the kinds of things we're doing. We also are very focused on, we believe that doing analytics of this nature is going to benefit hugely from the cloud. We're already seeing in many cases where our cloud-based operations are being used by medical companies. And not just hospitals and payers and plans, but people that are actually fostering up software that offers offerings to the medical industry. We have an EMR now that's on our platform. So we've got some very interesting things going on in the cloud. But one of the things I'll let you with is that we actually have a system named Health Vault. I'll ask, anybody know what Health Vault is? Hey, I got a couple. Anybody a member of Health Vault out here? Okay, I'll ask you later how long ago you made that membership and what your attitude is toward it. But one of the things that's interesting about Health Vault is it's a personal health record that we offer up to the consumer for free. But what's cool about it is that we have many medical devices that actually attach to that service. In fact, we have over 1 billion instances of medical devices that are touching that service. And they're things like, a pulse oximeter or, a weigh scale or a blood pressure cuff or a glucometer, things that can actually report information back into your personal health record. And we haven't chosen or asked people to opt in to doing anything additional with that data than getting it in their personal health record, but we do give them the ability to transport that data to whoever they would like to transport it for. So if someone wants to have the people opt in to maybe a study, we have data now physically available that we've collected. We're offering that service for connectivity for these sensors and capabilities, these personal wearables and all those types of things, as a service to the medical industry, and we're starting to see huge uptake in it. So I'll drop it at that. You can ask me some questions, and thank you.
Thanks, John. Joe, would you tell us a little bit about your perspective at this point?
Sure. We're able to put a little bit more resources away from just implementations and collecting all that data and actually using it. And I think one definition of that I like to use that I haven't heard today from big data to define it is it doesn't really necessarily mean how large the data set is. It could be huge, it could be small to moderate, but it's the ability to use that. Can we use it? Do we have the tools to use it? Do we have the human resources, which is a real critical restraint? That's the big data problem, not necessarily the size of the data set. And what is your journey and your path toward being able to make that useful data? And the word value has come up here a lot today, and it certainly has also come up in our organization quite a bit. We are working on a schema. We've only done a couple of projects now, but want to do about 4 to 6 a year going forward with our new partnership with SAS, where we're trying to prioritize our projects. And we actually have created a value scorecard to prioritize projects. And it's really the sum of the value score is really a sum of 3 things, which we all know about, at least in clinical medicine. And that is a variety of health outcomes based on the project or program. Patient experience has to be in that numerator for value. And these are all summations of this, all the health outcomes, patient experience, and then of course it has to be, you have to put cost into that equation, revenue and so forth in the financials. So it's really a sum of all those parts where we actually create, it's not a true ROI equation, But then also we won't want to do a project unless we can measure what that expected ROI is in all of those three areas. So it wouldn't surprise you to hear that, well, what's our data model? What's our integration model for, say, patient integration model? It would be bring in the silos of data into the warehouse to support those business use cases. So we bring in the patient experience data. We bring in the health outcomes data that might be related to all the readmission predictive that we're working on right now as one of our initial models. And of course, the cost data and actually the margin analysis. One of the really exciting things on the finance side is to do that arbitrage analysis of if this patient is a Medicare patient versus a commercial patient versus a bundled patient. How does that all come out? How do we do that trade-off analysis, which is very complex because you have to group those patients based on what you're trying to study and what your outcomes are. So value is something that is talked about a lot, but to be able to measure it is much more difficult, and we're on that sort of journey to be able to do that. I think the other thing, what's important to me in showing value in not just one particular area of outcomes that I mentioned, as a clinician, and I still practice a bit as a pulmonologist, and that is, you know, a lot of times as physicians, and I heard it a little bit here today, we're under a lot of directives to cut costs. So we get a lot of cost data because everybody runs a company, whether you're not-for-profit or for-profit, and you hear a lot about the cost data and the financial implications and so forth. But to bring to end users the proposition that there's a balance of outcomes. There's patient experience. There's health outcomes. Whether, if we're doing a sepsis alert, how many ventilator days did we prevent? How many infections did we prevent? And so forth. How many of those patients didn't go into renal failure and didn't have to go on dialysis? Now that's meaningful to the patient. It's also meaningful to the bottom line. So to be able to go to clinicians now with a more balanced portfolio of information and knowledge, I think is going to be huge. And it will, I think it will really set apart the projects that we're doing now with the knowledge that we're creating, because there's been a certain amount of integration between our deployment spheres, whether that be an EMR and other web portals of information that we pass on to clinicians and all of our stakeholders in our projects. And there's been, of course, being here at the University of Arizona and being associated with medical academic centers in my past, evidence-based medicine. And that evidence-based core that you have here and that we also have to some extent at Dignity Health. What's missing there is the confluence of the third circle, and that's analytics. If you aim to the center of those three circles with projects, you'll get the highest value and sustainable outcomes that you can think of. Because if you don't have the analytics there, then you're either creating science projects that you can't scale out, or you're making a company or an organization very lean, very Six Sigma-like, but you're really not scaling it out to be able to do that. So those are some of the just great areas transitioning in our organization between all the health outcomes that the clinicians have prioritized in the past and moving toward this more value-based payment system that we're all going to have to adapt and transition to. Thank you.
Thank you. Yves?
It's a pleasure. Actually, I'm one of those that has seen Dr. Welby when I was a kid. I'm not sure half the audience has even seen Dr. Welby. Who's seen Dr. Welby here? So I think, Wendy, you've given up your age already. Sorry to say. He was inspiring. Perhaps you and I are physicians because of that. So coming back to business, when I was in med school, the pen computers were coming out, so I started a startup with colleagues and realized rapidly that to put knowledge into it, and I think another thing that gave up perhaps the legacy is the SOAP from our colleague. It was published in '68, so I'm very familiar with the history of the SOAP format. And the language was incorrect. We had trees of data, such as the billing codes, flat data dictionaries, but no one was really using what I would call a naturalistic way of organizing the data, except perhaps two groups that I've learned later were developing it as well in the US. And they're now called ontologies or directed cyclic graphs. So that was the start of my journey in improving the language of medicine so that we could computerize on it. So, that Penn story get distributed in 2,000 hospitals. So I gained in 10 years a strong corporate experience while publishing and having an adjunct faculty position. Then I returned at Columbia University, decided to contribute to perhaps disintermediate tasks that were menial for physicians. At that time, physicians were not very happy to hear that. Nowadays, I think they welcome that. And we developed an event monitor that's been in operation for 12 years and illustrate, I think, the point that Joseph was making, which is what you want is dynamic analytics that adapts and rapidly can sort through what's going on. We had the opportunity over there to have access to one of the first extensive warehouse of the country, a data warehouse. In 1998, we already had 30 years of data, 6 million patients, and all the narratives had been coded into SNOMED. So we're speaking of radiology reports, pathology reports, discharge summaries, a wealth of information. And we could, within half a second, put together, a little bit like a Lego set, a system that would pick up an X-ray in the emergency room, verify if there were signs of tuberculosis, because radiologists wouldn't say tuberculosis, that would be helpful, but miliary metastases and so on. And then inform the administrators to isolate the patient, because the clinical pyramid in an academic hospital takes too long for decision making. Informing the senior resident or the intern or the attending may take too long, and the administrators were the right way to go. So as I received money from NASA to develop an event monitor that would use ontologies instead of flat data dictionaries, that would be more dynamic and more adaptive as the specific data type change, the rules can be are still valid. What we realized rapidly was that in spite of having hundreds of rules for quality, it was hard to quantify quality and move the leadership of the hospital in what it meant. Nowadays, I think that would be a proposal that would work, but we're speaking 15 years ago, and they were not really enthralled by saying that I would analyze 40,000 laboratory tests every day that appear within the normal range of the laboratory, but the AI artificial intelligence would go back to the whole record, look into trends, look into other parameters, and say, well, potassium level of 4.8 today and 4.6 yesterday. This is not working?
It's actually getting some feedback, I think.
Oh, sorry.
That isn't good. Just put it,
So having having a potassium level with a trend like that in someone that's got diabetes and arrhythmia as a past history is serious business. They may be in arrhythmia, within hours, and we should address that, especially because we've changed the therapy yesterday for a potassium-saving diuretic. So it could be a liability for the hospital. So the system could find these things, address them, 500 a day. It's been in operation 12 years and still doing that. But that didn't sway the leadership. What worked is a simple administrative rule again, because by looking into the data, I realized I was still practicing in the emergency room that the personal experience was actually a generalized experience, that about half of our homeless were veteran war individuals, and Vietnam War veteran, and they actually were eligible for an insurance because I called the vets and they told me, well, they currently can't get a card because they have no address. And what about the address of the hospital? And that would work. So all we had was to send a social worker to the emergency room when we'd pick at the admission that someone would come with certain parameters over 65 mil, one of the 10 chronic diseases we had identified, and a pattern of coming regularly to the hospital for follow-up of that chronic disease without an insurance and in the emergency room. So just that generated $1 million of revenue rather than cost reduction. In cost reduction, we didn't even try to calculate what we saved to the emergency room because they were moved to the outpatient clinics. And I think that's the whole balance. Are we working with reducing cost or increasing the revenue? Obviously, when we're at risk in the new type of organization, like accountable care organizations, it's not even an issue anymore. It's a good decision. So in big data here, the opportunity I see is that the major roadblock for decision support tools that could transform, disrupt, improve, augment physicians would be really to have the knowledge base dynamically improve with the knowledge of what's going on in the hospital. For example, the antibiotic resistance for certain patterns of microbes or other patterns that are not so obvious that we're looking on right now with the omics data set correlations with correlations of syndromes in the hospital, which perhaps have the same genetic underpinning. A good example is the metabolic syndrome that was conceived over 20 years ago, but there are probably other low-hanging fruits of syndromes right there because we can't analyze together genomics and clinical data easily. These patterns are currently not identified. So our group is looking into improving precision care at every level, including purely clinical parameters, but mostly if we could dynamically improve the expert system and knowledge bases, perhaps they would resuscitate, because I bet all of us panelists here have seen the publications of Mycin from Ted Shortliff and the later publications of a number of artificial intelligence used in internal medicine. And you know, they were compared, and the problem was that they were trying to make decisions instead of physicians, and they were extremely laborious for data entry and extremely laborious to maintain. So none of them, the Explain, QMR, Internist, they're all obsoleted. And if we could address these two barriers, and I think with the big data challenge, the heterogeneity of data and the fluidity of data, the data entry may become a thing of the past. What remains is how do we build knowledge that we can trust and dynamically so these systems can again provide advice, and rather than try to establish a diagnosis, perhaps help us in the treatment plan.
Thank you. So you see, we're very fortunate to have this group up here. I'm going to start off, I'm going to ask each of them a question, then I'm going to ask you all to chime in and ask questions. I'm going to ask Wendy first. You know, one of the big things, and I think you heard it today loud and clear, was that the patient is really the most underutilized resource we have when you think about it. And a lot of us are working on patient engagement and patient activation. And I'd like to ask Wendy about the fact that, how do you think if by increasing patient engagement or participation, how would that increase the analytical power of big data in healthcare, or would it?
I think that patient engagement is the key to increasing the power for a patient, for big data analytics, the power of it. And the reason is that really we only have data for when the patient shows up in front of us. We don't have data for all of the time in between, which is the majority of a patient's lifespan. So if we're able to understand patterns better, you know, in the old days before we had hemoglobin A1Cs, you know, a diabetic patient would, you know, behave themselves for 3 or 4 days before they came in to see the doctor, because we would, you know, finger stick them. And, oh, look how good your blood sugar is. And, you know, everyone wants a good report card. But if you can see when people are stressed or when people aren't coming in because of financial issues, but they're still communicating electronically through their Fitbits or through their online, you know, resources, we'll have a better understanding of what the pattern of that disease looks like, and we can make more informed decisions about treatments that we have to do and what our true outcomes are for our treatments as well. And we'll be able to understand the lifestyle implications of those treatments.
Thanks. So there's more to the story than just the medical side of it. It's right. And patient activation, Deborah Hibbert, who was at the University of Oregon, has done a lot of work in patient activation. And I remember telling a story to us at the Brookings Dartmouth Learning Network that how do you really get patients activated? It goes back to what Wendy was talking about. And she gave the example of a patient who came in and was eating 10 donuts a day. 10 donuts a day. I always wonder what happened to the other 2. But anyway.
Was it a police officer?
She was eating 10 donuts a day. And how they started to get her to change was they got her to start eating 9 donuts a day. So you have to really start where the patient's at. So it tells you that a lot of work, as Wendy's indicating, on patient engagement and patient activation really has to take place, and we're all struggling to try to figure out how to do that. I'd like to go to John next because I want to challenge him on the health information exchange because we started down this path, Michael could agree with this, a number of years ago with what's going across the state of Arizona. We had a southern Arizona, and we had all the players involved, and then we had HIN-AZ, and the health information exchange has been very disappointing, not only to me, and I think to a lot of people, but not only in the state of Arizona, but across the country, because I think the promise of registries and all that kind of stuff, from what I hear and talking to people across the country, and I'm not really a techie, but has been very disappointing and discouraging. Now, there's still the promise. But John, could you tell us where we are with that? Are we going to get to a point where that's going to be the answer? Or is it going to be something else? Or with big data, what do you think? Where are we going with that? I mean, you've obviously been involved in that.
Sure. I've actually been around health information exchanges for years. I actually used to work for Sun Microsystems, and at one point, the NHIN chose to adopt a lot of our stack as the NHIN Connect technology years ago because we open sourced it. And one of the things that we learned a long time ago is that we've got to drive down the cost of the technology in these HIEs to make it, number one, reasonable, but that's not the big problem. The big problem is historically there hasn't been a remuneration model for the HIEs. They usually start off with grant funding, they build an infrastructure, they struggle to maintain it, and they struggle to get people to purchase information and data in exchange from them. And so one of the things I would suggest is there's 2 major developments that have kind of started to occur that I think will help move the movement along. And I don't think it's going to be a rapid movement by any means. I don't think we're going to have an acceleration that's crazy. But one of the things that happened, and I work with a bunch of the electronic medical record companies in the business, is when the government came out and said we need to, for stage 2 meaningful use certification, be able to do 2 things. One is, if someone asks me for data about a patient, I need to be able to produce an entire record of everything I've done for that patient in my care. Right? I need to be able to produce that and ship it securely. The second piece, which I think is more important than the first piece, is that an electronic medical record system now, to be certified, has to actually ingest that data and put it in with other data in the electronic medical record environment. Now, it marks that it's not your data, so you don't take legal liability on it and everything, but it actually gets the data to the point where a doctor or a nurse sees it when they're actually moving around and doing something. Those are 2 big decisions that were made in meaningful use that I think will help move along the HIE footprint. The second piece I think that's going on that I think is going to help it is I talked earlier about we adopt technologies where we're incented. I think with the change in the way we get remuneration in healthcare and the fact that we're going to more of an accountable care or bundled payment or whatever the model is of tomorrow, but there's the risk that's moving from what traditionally was the payer who managed the financial responsibility to a person that can actually manage the interactions with the patient, the provider. And I'm seeing that there's a lot more interest in making sure that data is available to them, all the history and all the capabilities available to them as they're trying to make those decisions, because now they're financially at risk for that life. And so while I don't think it's going to get hugely better right away, I do think there's a couple standing blocks that are there that we can build on to actually make the HIE model move forward. I will leave you with one other thing, and that is that for the first time ever, and I thought this was revolutionary, 2 years ago, there was actually a movement by the EMR companies to start making an interchange. Anybody heard of Commonwealth? So that was actually a lot of the major, not all, but a lot of the major EMR providers got together and said, we're going to start exchanging data. We're going to create a place for this to happen. We're going to create a place for identities to occur so that Dignity can ask Banner for a patient, and they can figure out who that is, and so on and so forth. So there is some movement in the industry, but yeah, I've seen a lot of them start, and I've seen a lot of them die, and typically it's because there's not a value case that they can get someone to buy off on the other end, unfortunately.
Yeah, it's been sort of discouraging when
Yeah.
you think about on the whole, really. Joe, I wanted to ask you, because one of the areas you've been interested in and done work on is governance in this whole area. And how do you govern health analytical resources in your organization, and how are they aligned with your long-term strategy? Because I think that's an area that we don't know very much about, and with your experience, maybe you could enlighten us on that.
Well, I thought I knew something about governance when we went through data. You gather a fair amount of data governance, which I'm sure you have at Phoenix Children's as well, Wendy, regarding change management governance.
If you pull the microphone over to
for your EMR.
Yeah.
And so that's a little bit more tactical, a little bit putting tickets through and improving efficiency and so forth, but short term. When you get to like MDM, Master Data Management, data governance for the whole organization, then you get into a lot of different issues. And we do have a very, we started to engage, we have a governance structure, a very engaged executive council, which will help us weave through this for the support that we need. One of the priorities right now, operationally, it was fine to have an EMPI that was regional. So in other words, why do we have to have a master patient index or a master provider index outside of Arizona? Our patients are in California, Nevada, and Arizona, predominantly on the inpatient side. So why even in Southern California does Sacramento necessarily have to, have a unique identifier? Well, then our data warehouse strategy came. And so we want to create longitudinal patient records to be able to have the maximum granular value to that information. So we have to merge charts better than we've been doing. We have to do it more efficiently, and we have to quit paying by the drink. Right now, we have a very good probabilistic algorithm that we use from a very good partner in that. However, we want to develop our own. We want to kind of build a better mousetrap that's faster, better, and cheaper. And we think we can do that with analytics tools. We can take what product this matching score gives for matching patient records and improve on it and iterate it and use machine learning. And that will also reduce the amount of manual abstraction. That's a huge cost, and sometimes up to a 3 or 4 month delay on the tens of thousands of duplicate records that are sitting out there. And most of all, as you probably all know, something like 51%, if there are 2 records and they remain apart, 51% of the time there are labs that are missing from one or that other chart. And 18% of the time, this was an ACMIO study that was done last year, those labs are abnormal. So physicians are not necessarily going to look in 2 or 3 charts or guess it's John T. Booker instead of John T. Booker. They're going to look up John Booker, they're in the hospital, they're going to look at it. There's a real barrier there to looking for a 2nd or 3rd chart and finding that other lab. So not only is it, they're missing the information, but what are they going to do? They're going to order a 2nd lab when it was done a week ago. So this is a big push in our governance to get that we call it now, we're calling it a universal master patient index and also provider index. And where we want to go with that, with governance, is then get a master consumer index to identify potential patients, to make sure that we hold that master in the enterprise data warehouse that we can identify and do analytics with. So those are the big things in the governance area that we're setting off on, big projects, but analytics will help us get there, and overall, it has a lot of benefits downstream to the organization.
Thank you. Yves, a couple things on the cancer side. We've done, when you really look at the standardization and quality that's coming out of the oncology area, it's been probably one of the leading areas But we still know, for example, that 20 to 30% of people who are going to die are within a month of dying are still getting chemotherapy, all those kind of things. Well, and we do know that probably, I just read something from the advisory board that Michael Griffiths sent me, which was that 98% of the data from cancer is gone. We don't know what's going on. So could you talk a little bit to what you're seeing in that area in terms of quality improvement, and how do we really change physicians' behavior so that these people are not being put through this through the end of their lives? Maybe we all ought to get the oncologist all to read Atul Gawan's new book. Maybe that's probably the way to go.
My former colleague from Columbia University.
Yeah.
So I think there are actually two questions within yours, or at least I'll divide it into questions. One of them is really much more on the way we manage cost efficiency in the U.S. as compared to most other countries in the world, in which our healthcare system that's so-called private really consists of probably 70% of the procedures are conducted in the last 2 or 3 years of life of an individual. That occurs generally after 65 when someone's over Medicare. So if the cost of these procedures under Medicare were the same as those that are privately insured, I can assure you that Medicare and Medicaid wouldn't be only 50% of the overall health budget we have in US. So we're already at 50%. And then if someone can't keep a job and they use up all of their money, they'll likely before 65 become under Medicaid. And again, there's a net there of security. So that gives you an idea. If there's less than 20% of the procedures that cost half the money in this country, what's the cost per procedure we're paying as compared to the other countries, and why, on average, we have the overall cost of the healthcare system that's about twice that of Canada, Great Britain, or others. I'm Canadian originally. I'm a dual citizen now, and I've been on board 4 hospitals there, and we went through the gruesome difficulty of reducing the cost by 30% in 1 year, and then 50% cumulative in 2 years, and it was difficult. Hard choices were made, but no one was competing with us. In other words, we could take care of a region of 1 million people with 4 hospitals, turn 2 into geriatric hospitals, augment the capability of the others, tell the 4 administration there's only 1 administration left, tell the 4 department chairs there's only 1 left, and organize, and the nurses made it all come true. The physicians were a bit harder to herd, but it worked out. Here, the difficulty in the US is that as soon as we start moving one part of the system, there are opportunities where others can cream the top of the market, and you got to be really careful to not lose your money generating patients. That problem is much bigger. I think I can state where the problem is, but it's hard to solve. I'd like to look into, cancer is one of the revenue generation part. I'd like to look more into the area where the omics and precision health is probably the most advanced, which is really cancer. And that's an area of research I've worked in for 10 years now, and I've helped with Dr. Mendelsohn, the former president of MD Anderson, start an international conference called the WIN Consortium, where every company and researchers go present their N-of-1 solution. How did they treat 1 patient and with an original treatment, and it works? How to design these clinical trials. And that has been moving so fast, it knocks my socks off every year. If those of you that have heard of Foundation Medicine, that was started in Boston by Luminary, the Broad Institute head, and that's a company that just said, we'll just look into the 250 top oncogenes in cancer and scan and look into all of the cancers for these. It's not a new idea, actually. It came from Van Huff, the former director of our cancer center here, who's now at TGen in Phoenix. So it's a local idea, but the group that will make the money is in Boston out of it. So and within a year of announcing that in our meeting 2 years ago, they presented that it took them 6 months to get their technology to the point in which it could do deep sequencing in these 250 genes out of paraffin-embedded blocks, so the standard of medicine. In the last 6 months, they received 5,000 orders. A third of these were patients with no known primary. Well, I remember how hard that was to treat. You go to pathology, you say, so the lung cancer, well, it's metastasis. And then it's ovarian or breast, the primary. MRI, CTs are all negative, and it's telling about how our immunity can cure the primary cancer sometimes. So now there's no standard of care. The NIH doesn't fund diseases that don't have an organ of origin, and that's how it's set. So the physicians were not really knowing where to go, and there's a few protocols, but Foundation Medicine, for these patients, they were already giving us the data 2 years ago that for 1,600 patients, they had at least 4 genes in which they could find a significant mutation, like a missense mutation or a gain-of-function mutation. And one of these was in the pathway that was actionable with a drug. And in spite of having only 6 months of follow-up and no obligation on the part of the clinicians and patients to provide any feedback on the treatment, they already had 7 anecdotal cases that survived longer in the second treatment without recurrence of the disease than the first one. Well, if you're an oncologist, you know this is really, really rare. Usually the second treatment, it's diminishing return. The failure to first therapy is a gain of 30% of the mass size or new metastasis. So if the second therapy beats that, it's amazing. 6 years ago, we started trying to reposition drugs. So we received NIH funding after confirming bioinformatically, then in vitro and in vivo, that we could rescue a targeted therapy in head and neck cancer. And earlier this year, we presented with our multicentric clinical trial that it worked. So the trial worked in human beings. It cost us I would say $100,000 of computation. The animal models and serial models were less than $100,000. We received $300,000 for the clinical trial from the NIH. Within 4 months of providing the results in less than 2 years. Compare that to the pipeline of drug discovery of the past. 1,000 compounds start, you spent about $20 million, and there's 5 or 6 candidates after the animal models that come into clinical trials. You spent phase 1, phase 2, phase 3, another 5 or 10 million, and then there's only one that will go in phase 3 that will be successful. And you've spent about $100 million for that one successful one. Repositioning a drug computationally and then validating it biologically, we could show we could do that, within a margin of $500,000 and getting to a successful clinical trial. Why could we go with such small numbers? Again, it's because of precision health. We now knew what was the molecular target. We could design the therapy so that a handful of patients would prove it works. It was really tough design. We would treat them when they had failed the primary therapy by keeping the primary therapy and adding the second one that would rescue it. And so we have those cases where adding the second therapy prolongs the treatment. Now, the secondary therapy was tried alone a long time ago in head and neck cancer and failed through an FDA-approved clinical trial. So it's the combination of the two, as we had shown computationally, that was a lethal combination and not one or the other.
Good. I'd like to now turn this, or at least open it up to the audience for questions. So are there any questions that this distinguished panel can answer for you that you might have?
Gephardt from the College of Nursing. And my question relates to health information exchange. We often talk about getting big data so that we can make better decisions. So the idea is moving the data and the predictive analytics or whatever so to impact the clinical decision making. Yet we ask patients to give us data. But when do we push it back and we give them the data? It seems rather inequitable to exchange it among ourselves but never deliver it back, or to incompletely deliver it back to them. And I'm curious what you all think about that. I specifically was thinking of those who commented on the personal health records and the health information exchange.
Who would like to take that? John?
I'll take a shot at it.
Okay.
So it's interesting because one of the things that we've done with Health Vault is we've created the ability to move data both to the provider and away from the provider back to their personal health record. And obviously it's a resource we provide to folks. Actually, as a consumer, you get it for free. as a participating physician or partner, you would actually have some integration costs to do. But we give it to them for free because we actually do believe there is a certain portion of the population that's going to use and leverage that and move their data around. We integrated it to a telehealth system called America Well. So if you ever get in an environment where America Well's at and you do a health visit, you can both give the data to your physician that you're going to visit on that telehealth platform from the personal health record, and then you can get all the data back that they deliver from that perspective. But having said that, you know, there is that debate in the world of, do we keep it as providers or do we share it with patients, and when do we make them responsible for moving their data around versus us responsible? And I think that has a lot to do with, you know, who the person is and what the characteristics of that person are. Because I would say to you that in the new generations, most of these people are accustomed to doing that. But I grew up, I know Dr. Welby, right? I grew up a long time ago, and when I went to the doctor, I listened to my physician, and I depended on my physician to tell me what to do. And if my physician didn't say, move your data over here, or go to a competitive physician, or go get a second opinion, I didn't do that. So I'm in that paradigm that's probably not ready yet to manage my own personal health and move it around. I would trust my kids more with my own personal health record, frankly, to move it around than I would. So just a viewpoint on it.
Can I add something?
Yeah, Wendy.
So meaningful use requires that we do share with the patient. It requires that we provide them an end-of-visit summary after seeing them on the ambulatory side of the house that has their medications, their problems, what the goals and the instructions were for today, any changes to their medication. On the inpatient side, it requires that an end-of-visit summary in a format called a CCDA, which is a very structured format with specific data points in it, is available to them. It requires that within 72 hours of the availability of a test result to a physician that we release it. We do have the ability to have exceptions so that people aren't getting bad news independently. So there is a lot of movement to move the records toward increasing the amount of the data to the patient. Open notes is a movement, and that has, you know, been used in many organizations. There are many cultural barriers that will have to be overcome with that, but I do think we are moving in that direction.
Thank you. Michael?
Hi, Michael Griffiths. I'm the IT director at Tucson Medical Center, responsible for interoperability and also analytics.
A graduate of this program.
And an MIS graduate. Go Wildcats. So in the healthcare delivery system, the tip of the spear, so to speak, is the EMR. And yet, a lot of what we've talked about today in terms of producing analytics, producing insight, is not happening inside the EMR. It's happening in other systems, whether they're homegrown or platforms that we purchase. Yet we're heavily reliant and beholden on the data that's coming from those EMRs. What are some of your thoughts and maybe some things that your organizations are doing to really push those insights that we might gain from analytics platforms back to the tip of the spear where care is given and they would have the most impact?
Joe, you want that?
Comment on that. Yeah. You know, two of the largest vendors who remain nameless here, but one is used by University of Arizona and the other one by Banner and Dignity Health. You know, they have a very...
And one is four-lettered, okay.
Yeah. One is four-lettered. It's not a bad four-letter word, though.
We do.
You know, they have very robust data tables and metadata dictionaries and so forth. It's very usable as far as sourcing it to a data warehouse. Sometimes the results, because of the amount of non-discrete data and blob text that's entered through typing or dragging, is a bit messy because they've left it open. You know, smoking cessation can be documented 16 different ways. We can't mandate it in one way, especially when we want, you know, we're begging people to get on the EMR the first few months. So there is some messiness there, but it's good. It's a good amount of structured data and so forth. The issue is the industry doesn't have the interoperability. Mm-hmm. So that if I acquire another health system, which may be going on here in Arizona as well. And it's these two companies, to use that as an example. It's very hard. It's very hard to, then you have to come up with maybe even new data definitions about what smoking cessation means from one system to another. So, there's a lot of good data there. It's messy, but if you're dealing with a different outpatient system like we have as well than an inpatient system, it's not as interoperability because the industry is not cooperating in doing that. Does that make sense?
Other questions? Dr. Slepian.
On the same line, we heard an issue about pushing the data back to the patient. We heard about pushing the data to the head of the spear. And I want to ask about the analytics, let's say back to the patient. And also to give my age, we could quote a Johnny Carson type thing, which is man goes to, or woman goes to the doctor, and the doctor says, I have some bad news. Bad news is you have one day to live, and what's the other really bad news? I forgot to tell you yesterday. So, if that type of thing goes to the patient, how are they going to handle that information? What are they going to do? What level of analytics or predictive analytics can we give to patients with an empowered process? It's one, if you give them a whole jumble of data, it's not really, it's pseudo-knowledge to them. Sure, I have this level, I have that. What am I going to do with it? And then if you start telling them, well, this is happening and that's happening, are we trying to convert patients to healthcare professionals? Think about it. Comment.
Interesting question. I don't see a lot of takers up there. So, Joe.
I'll just make a quick comment, and then I'm sure somebody else has a comment as well. I think when you do a business use case for analytics, part of that is end-to-end data, end-to-end process, and hopefully in the future be able to map end-to-end patient experience. In the process part, in the data part, what you try to do is establish who are those consumers of the data. There's all these different personas, and that's a word I'm stealing from SAS, from their workflow analysis and models that they use to do projects that we're starting to use, and I like it because that knowledge, there's different knowledge for administrators, there's different knowledge for clinical leadership, and there's different knowledge for patients and consumers and so forth if it's, say, an ambulatory project that we would want to push out through the portal. So it's actually asking them, that persona, that consumer of the information, what would be useful to you, what might get you to be more engaged in your care and so forth, as opposed to what we would push to the CMO or to the hospitalist in that particular case. Depends on the business use case. But if you can map that end to end and create those personas, that's at least a start. And then the nice thing about analytics is it's not a dead end anymore, right? We can say, this is the recommended action. Well, what happens? And what happens over and over again, we'll iterate that and make it a better model, hopefully.
As a family practitioner, 90% of what I will sit down and do with an adult is negotiate and discuss how they can, excuse me, how they can decide what their future is going to look like from a healthcare perspective. I have always done calculators with them and sat down and said, you change this and your risk of a heart attack over the next 10 years is this. If you change that, your risk is this. Those are very primitive. But I think that if we could be able to provide them with larger data sets that say, you're running because you're running 3 times a week now and you've lost 10 pounds, now your risk of this, and this is reduced, I think it reinforces the positive behavior change, and then the positive behavior change gives better health results cause more behavior changes, and we start a positive cycle. Now, the key is figuring out what the trigger is. For some people, if I tell them, when you diagnose somebody with hypertension, right, you say, well, we can do 3 months of diet and exercise, and if that fails, we'll do a pill. And I have people who will say to me, just give me the pill, because it's going to fail. That person, that's not the right trigger for them. It's really understanding and figuring that piece out, which I think we have a lot of growth potential to be working on the whole behavioral informatics piece of things.
So a lot of work we're doing with motivational interviewing, teaching our physicians and providers to do motivational interviewing. What is it that the patients need right there? In fact, we're working with the MBA students at Eller, our patient engagement committee of our accountable care organization, to really develop a model, and they're doing it right now. They're doing the project right now of what are the questions that we need to ask patients that they're going to respond to. So we're asking the patients, what is it that they want to accomplish and it's just 3 or 4 questions that they're asking, and it's all done through a portal electronically. So we're looking forward to getting that data. We've done some preliminary work on it, but it's really starting out from exactly what they're saying is, where are the patients? What is it they really want? And how do you start from the lady that's taking 10 donuts a day, kind of thing? So, other questions? Brian, I'm sorry, go ahead.
My name is Barbara, and I'm from Northern Arizona Healthcare. And one question that's come up a lot in, I work in quality management, is HCPCS codes. So we're extremely interested in medical devices, as well as devices like Fitbits, regular things to monitor and help with population health, an upcoming measure. But one of the problems is a lot of our patients in our region don't have monetary means to go out and purchase these types of devices, and there doesn't seem to be a way that we can get them through on the insurance.
Yep.
And I just wonder if there's been any thought to incentivizing patients who want to become engaged. We do use motivational interviewing, and they're very interested in this type of information, but they can't seem to be able to afford it.
Yves.
Disretized self. Well, I think the device alone serves no more than traditional pedometers. The Fitbit concept is really that you got your social network that starts influencing you because you start exposing certain parameters to your friends, your colleagues, your family. They share theirs, and then there's this positive side of competitiveness we all have in ourselves that stimulates you to go to the next step. And there are probably other ways to obtain this motivation that would be more affordable, but the question is whether we can create the network. Again, the web portal and the web tools and traditional pedometers can be bought for $10 or less. Could be offered open source, there could be other, I guess, less non-for-profit organization that could help us generate that. That would already lower the threshold and out of what I would call the elite crowd back to, and the early adopters back to everybody. It would still require some personal data entry, which is a bit laborious, and access to a computer, which is, again, I would say for certain population, it's probably more the cell phone, not necessarily a smartphone.
Yep. Just
Texting to a number. We've looked into that in Chicago, and indeed, the savviness of a segment of the population, which we would have considered would not have access to computers, and that was correct. We're actually much more savvy at using these devices than another segment of the population that had computers sitting at home. So leveraging, I would say, that acumenship of using texting and cells with some parameters could help. But there's something much more fundamental, which are the food deserts, fresh food deserts, and segments of the population that are at risk of obesity. And that goes also with habits learned early in life and the taste that develop around these habits and so on. It's a much bigger problem, I guess, to address. But indeed, there's many opportunities to discretize health now. The electronic records don't seem to be pulling that in right now. Wendy, have you seen any of the vendors looking into interfaces to these devices? Or
Yeah, the vendor that we use for our patient portal can bring in Fitbit and those kinds of information into it. Also, what you're seeing in private insurance is that private insurance is now starting to get skin in the game, especially in healthcare private insurance and tech private insurance, where if you wear a Fitbit and you upload it, you'll get X amount of credits towards, you know, your deductible will be decreased. If you sign up for a class, your deductible will be decreased. If you do different things. And I think we'll see more of that evolving. And there are a couple state Medicaids that have played with that as well. But I think in the underserved population, and I've spent a lot of my career in the underserved population, group visits can serve that same function. You can actually have someone come in and you can do a group activity together, have group walks and things like that. And Microsoft has a program they're working on with free software or smartphones as well.
Yeah, so what we did with all our technology is if you buy a device that's under 7 inches, everything that goes out on that we OEM is a free platform. So we've gone to that mode, and that's very helpful to a lot of the carriers and those guys that want to put something on a device like that. But the other thing I'll say that's kind of interesting is we've watched a little bit of the adoption of these devices because we actually have this network of devices that are coming into the personal health record. And what we've noticed is that there are some correlations between when employers incent their people to engage in a personal health record and to engage into a digital platform, we're seeing large spikes of uptake, right? So it is a little bit about making sure people understand the value and benefit. And what we also noticed in that little bit of data we pulled is that there are self-insured employers that are driving that much quicker, much easier than you're finding if you're not a self-insured program, right? So again, I think it comes down to when the incentive is right, we're going to see that kind of behavior. And I believe that you're going to start seeing that as an ACO takes over control of, you know, my care. And, you know, it's now a cost opportunity whenever I'm sick as opposed to a revenue opportunity. I think you're going to see some of that behavior change. I've already started to see some modeling around prescribing various different devices to certain people. So.
Yeah, there's been some recommendations to CMS from the Brookings Dartmouth Learning Network regarding how do you incent patients financially to really start to do it. And part of it is with the ACO movement to really decrease their co-pays and things like that. But I'll just give a perfect example. At Tucson Medical Center several years ago, the employees were looking at an increased cost of about $500 for how much they had to pay for their insurance. And what Judy Rich did was say, okay, if indeed you do these 4 things, that we will not put that in place, that you will be excused from that. One of it was a health risk assessment to visit your physician. The other was getting on an exercise program that you could document. The other was going to see a dentist and get a tooth cleaning, and there was one other thing. But there were these 4 things where you saw your primary care provider, you did a health assessment, you participated in an exercise program, and you went to the dentist and got a tooth cleaning, and it was amazing, the uptake on that. So those kind of incentives, and it looks like from the data I'm seeing from the Institute of Medicine, that there's about a $500 tipping point. That seems to be the tipping point where people will do things. There's some payers who are saying, well, if you do this, we'll give you a $10 movie coupon or something to Starbucks or something like that. But I think it's going to take more than that. So one of the recommendations to CMS from all the work we're doing on the ACO side is what are the kind of things you can offer patients from the standpoint of incentives financially that really is going to make a difference in their lives. So the kind of stuff they're talking about, the incentives are very critical.
So one other thing that needs to be considered with this discussion, especially if the Fitbit data goes directly to the insurance, from an ethical perspective, how can we ensure that there is no abuse of the data? Because if you have specific information where certain people may be not following up with fitness requirements, nutritional requirements, etc., there's also a risk, which at least in European countries with some insurances, there's issues with that, where all of a sudden you might be excluded from certain services from the insurance. That's something that I haven't heard much discussed here. So what does it mean for us if we provide all this information to insurance companies or even also to hospitals, that there won't be any exclusions in care in the future?
Well, you know, you've raised an interesting question because it used to be thought prior to the Affordable Care Act that this was discriminatory. But in the Affordable Care Act, there's the Safeway provision, where the CEO of Safeway was able to offer his employees incentives to be able to do with their health. In other words, if they control their blood pressure and take their meds and control their diabetes, that they could offer a health care plan that was less costly. And so that's in the Affordable Care Act. That's the first time we've seen something that says, you know, used to be thought that would be discriminatory. So there's movements to say, how do you really incent people on the quality side to do the right thing? And there may be some issues that I think you raised some good questions. What are the ethical side of that, which has to be answered? Anybody have any thoughts on that one? John?
Yeah, I would say we battle that every day. I mean, we do have a personal health record, and we're very careful about making sure people put stuff in there, they guide where it goes. And I would suggest to you that there were competitive players in this market segment that historically wanted to mine that data, and they've gotten out of that segment because what they've realized is that the criticality of that information could be a real problem when somebody shares that information. We've happily welcomed all those players that were in that space over to our area, but we have this dilemma every day. That, you know, we've got health data sitting in our environment that we don't share with anybody unless the patient says, I want to share it. And you know, what if, you know, there's actually, I feel like there's a bit of a moral dilemma there. What if we actually could find that there's a problem that we could help that person with, but we're not able to do that because we can't access the data? So it's a balancing act that we all have to struggle with, unfortunately.
We actually are running out of time, I think, so I really want to take the opportunity and to thank this great group of people in the panel and for the discussion. So please join me in thanking them for this great. Thank you.